The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and it's a pleasure to be hosting this podcast, and thanks to everyone for listening in. Today, we're going to talk a little bit about some major Medicare Advantage and Part D policies that have been finalized in recent weeks. I did a podcast back on March 8th regarding the audit picture in 2024 and a brand new prior authorization rule that came in 2024 that I really believe is misguided and will lead to a major increase in medical expense. So if you're interested in learning more about, audits as well as that prior authorization rule that went in effect on 1/1/24, please go back to that March 8th podcast and listen to that. But today we're going to be tackling the 2025 policy and rate changes in this podcast. And there are really sort of two documents that we're going to be talking about. Number one is what we call the advance and final notice that is issued between January, finalized, and early April. And this is sort of laying out the rate framework for 2025 for Medicare Advantage and Part D plans. We'll focus specifically on Medicare Advantage plans and what rates may look like for 2025. And we'll also touch upon some star measure changes because that notice essentially also lays out some futuristic things on star measurement as well, in addition to some other policies. And we'll do that sort of in the first third of this podcast here. The second major development is a rule that was introduced in late 23, finalized just recently as well, and it's known as the 2025 Medicare Advantage and Part D rule. And this goes through the formal rulemaking process, and there were just a number of different policy changes that build on what occurred in 2024 that will go into effect in 2025. So for about 2/3 of the podcast, we'll cover the 2025 Medicare Advantage and Part D rule. We'll be taking two breaks here. Again, one right after I talk about the advance and final notice about rate setting and some star stuff. And then the last 2/3, we'll break that up with another break. So two breaks as we normally do, one on the website and one on how to purchase my book. So let's get right into it here. So again, what we're going to be talking about first is the advance notice and the final notice. Again, the advance notice was sent out in late January, and the plans have the ability, and the general public has the ability to make comments. And in early April, the final notice came out and sort of laid out the rates for 2025 and as well as some of the star changes going into 2025. So basically, just to set it up a little bit, let's talk about the rates first. So MA plans are very worried about what their rate increases are going to be moving forward because they're seeing a couple of different things. Number one, they're seeing rising utilization and medical expense, largely because utilization is returning to normal post-COVID. It took a couple of years to do that. We're also seeing moderately aggressive inflation. So the two of those, utilization, inflation, is driving up medical expense. Again, I mentioned the prior authorization rule that was effective 1/1/24 that I really think will tie the hands of health plans and further drive up costs. In a nutshell, the prior auth rule significantly limits the use of outside evidence-based criteria by the plans in favor of just having them use the fee-for-service traditional program criteria and policies, which to me doesn't make a lot of sense. You're essentially saying to managed care, which is meant to save dollars, hey, you can only use what we throw out there for the unfettered fee-for-service system. So again, doesn't make a lot of sense, and it's going to drive costs even beyond that rising utilization and moderately aggressive inflation. There's also a new risk adjustment data validation rule out there that is being challenged by some health plans, but that poses significant industry risk because it could have retroactive recoupments and sort of aggregating audit findings across all of plan revenue. And lastly, of course, we have poor star achievement. And that is a little bit of the fault of plans because they took their focus off star during the pandemic, but also there are some significant new measures and weighting and some new ways of calculating star that also led to significantly lower star scores. So all of those four things sort of come together to create a problem for MA plans in terms of their margins and really medical expense. So if we go prior to, say, 24's rate increase, there were some fairly sizable increases in Medicare Advantage rates. And it sort of floated plans through the pandemic, and it allowed plans to add rather significantly to benefits. And we also were seeing fairly healthy star scores during that period as well, 22 and before, because of some pandemic flexibilities and things like that. And we saw rises in star scores. So generous rate increases and rises in star scores allowed plans to really enhance benefits a great deal. Well, in 2023, we started to see star scores come down a bit. In 24, we saw them come down even more. And that's beginning to tighten revenue moving forward for plans in general. In 2024, we also saw a final rate that, depending on who you listen to, was anywhere between minus 1% if you listen to health plans, or was about 3% if you listen to CMS. And that was a significant tightening in 2024 of rates for sure. I'm going to get a little bit into why there's this major difference in interpretation. So plans would have said in 2024, they got a negative 1% rate adjustment. CMS says they got roughly a 3.32% adjustment. But in 2025, again, we're seeing what plans would say are very tight rate increases. The proposed and the final rates essentially came out roughly about the same with minor adjustments up and down in different categories. But the 2025 final rate is going to be, if you listen to plans, again, a negative 0.16% increase. And if you listen to CMS, it's about a 3.7% increase. So why the difference? Well, CMS counts within the rate hike what's known as the anticipated risk score trends. Every year, risk scores tend to trend upward. And CMS and some critics of Medicare Advantage believe that that is due to overcoding by MA plans against fee-for-service as one example. Now, MA plans will tell you that they are simply coding in real time to essentially record changes in risk out there in populations from year to year. And they would argue that that risk score trend is really simply a recognition of increased risk. So you cannot include that in a rate increase. I happen to believe the truth is probably somewhere in the middle, that there is some aggressive overcoding every year, but there is some better coding by plans compared to fee-for-service that really does recognize historic risks, but also risks moving forward from year to year. So my interpretation of this is I wouldn't say by any means, rates are going up by 3.7% by including the risk score. I might split the difference and say that perhaps rates are going up not by negative 0.16 or by 3.7, but let's just say somewhere in that 2% range if we want to split the difference. But in and of itself, even that 2% increase is not keeping up with all of the other things we talked about. The rising utilization, increases inflation, the fallout that we expect from the prior authorization rule, and some, obviously drops in star revenue. So in and of itself, this MA rate increase of negative if you listen to the plans, or 3.7 if you listen to CMS, or perhaps if you listen to me somewhere in the middle at about 2%, this is going to be a real challenge for health plans going into 2025 for sure, given all of the negatives we're looking at. And so that's a very, very significant thing going on. Now, what I would tell you is that the base effective growth rate in fee-for-service, on which rates in MA are sort of calculated, actually did go up by somewhere around roughly 2.3 to 2.4%. And so that was a positive thing, number one. But what is really bringing down the rate increase, not only in 2024, but in 2025, and will again in 2026, is a brand new risk model revision that CMS has put in place that is really trying to tackle what they view as that overcoding phenomenon. And so they are phasing in this risk model, a third in 24, a third in 25, a third in 26. This revised risk model, which tightens what you can recognize in terms of diagnoses codes and the impact that they have on the risk scores, in a nutshell, is probably going to take out somewhere around, I'm estimating about 7% out of rates overall over that 3 years. So somewhere about 2.4% or so is the reduction in 2025 for the 1/3 additional phase-in. And that essentially cancels out that effective growth rate. So that sort of brings that rate to that negative 0.16%. And that is really what is leading to trouble for MA plans. Now, what I have alluded to here is that we will see the same thing happen in 2026, right? We'll see the last third come in. The effective growth rate will probably be canceled out. So in truth, we are looking at very tight rates for 2024, for 2025, and then for 2026. Again, with a lot of increases in medical expense. So likely what I pointed out in our March 8th podcast, we will start to see is plans are going to have to realign to meet margin expectations and things like that of investors, especially among the 75% of lives that are controlled by sort of the big players. And so what's going to have to happen is that benefits are going to have to be reined in. All of those really big benefits that happened earlier in the decade will sort of start to come out, and you will see a significant diminution of benefits because of these very, very tight rate increases. On one hand, I understand CMS's goal of trying to pull some overcoding out of the program, and I don't philosophically disagree with what they're trying to do here. But I also don't think they understand how significant benefits are going to be reined in here. And I think they're only going to figure that out after the benefits come out for 25 and then for 26. And suddenly they're going to be getting major complaints from Congress, and Congress is going to be getting major complaints from constituents because benefits were eroded. And as I always indicate, the Medicare Advantage program is perhaps the single greatest social safety net program for fixed income seniors and the disabled and the low income among senior populations in this country. They rely on it to close critical healthcare benefit gaps that actually exist in the fee-for-service program. And these folks can't afford expensive Medicare supplement policies to take those gaps away. And historically, MA plans have done that. And unfortunately, I think you're going to continue to see benefits to erode because of some really fairly strenuous things that are going on at CMS against MA. The prior authorization rule, as well as the rollout of the significant new risk model that is essentially taking all growth out of rates from 24 to 25 into 26. And the combination of falling star scores really makes things even worse there. So that's just sort of a recap of rates. What I'd like to do now is give you a quick feel for some of the things happening in terms of star scores within that final notice that came out there. Well, basically, what happens in there is that they're basically laying out some changes that are happening in the 2025 star ratings, which are going to be coming out in October, and plans are busy trying to keep those scores up. And based on 2023, most of the data is already in, but there are ways to improve scores throughout 2024. But as a reminder for 2025 star ratings, they basically laid out the star measures and the weights, not really many changes from 2024, with the exception that a measure that plans do very poorly on, called plan all-cause readmissions, is actually being rated a 3 weight now from a 1, which creates major problems for plans because they do very poorly on that measure. And breast cancer screening is also being converted to electronic only, which impacts the use of chart abstraction for hybrid data. So that's a pretty major change as well. And then lastly, there's an overhaul, a removal of one of the questions in the CAP survey related to getting appointments and care quickly. So those are the 2025 star rating changes. In 2026, both previous rules and the advance notice speak a little bit about some of the 26 changes, which is the 24 measurement year, which plans are working on right now. Colorectal cancer screening, like the breast cancer screening in 25, in 26, colorectal cancer becomes a electronic measure only, which again impacts hybrid chart reviews. The many of the CAPS measures, the survey measures, which are weighted a 4 in 2024 and in 2025 star, will drop to a 2 weight in 2026. Plans have struggled with those measures, so that will help overall scores perhaps a little bit in 2026. There's a couple of new HOS measures coming back, which are called improving or maintaining physical health and improving or maintaining mental health. They will come back into the HOS survey, which is another type of survey that CMS directly conducts based on a cohort and tries to ascertain quality performance over time. In 2026, there's also a brand new clinical measure that's coming into STAR. It's called Kidney Health Evaluation for Patients with Diabetes, and that's going to have a 1 weight. And lastly, there's some continuous enrollment for medication adherence measures and one of the statin drug adherence measures. So those are sort of a quick wrap up of what previous rules as well as this final notice for 2025 said about 2026 star ratings. I would also note that both rules as well as the final notice also discuss things related to future years. And I won't talk a lot about this, but a couple of the major changes here are there is a reward factor that awards a 0.4 extra rating in star ratings. That is going away in star 2027. It is being replaced with a health equity index that will award that same 0.4 up to that amount on star ratings. You have to essentially have enough impacted people that meet this demographic for health equity. And you also must perform well on it to get all of that 0.4. So a major change in health equity coming into star ratings as of star 2027. I would note that some data from measure year 2024 is the baseline for that rating. So plans really have to prepare for that now as well. There's a returned measure, the updated Care for Older Adults Functional Status Assessment for the 2027 star rating year. There's also two new medication adherence measures coming in, the concurrent use of opioids and benzodiazepines, and there's also a polypharmacy measure, both of them coming for the 2027 star rating as well. There was another med adherence measure proposed that also dealt with polypharmacy, but it will not become a star measure, it will become a display measure. In 2027 star, there will be the removal of the medication reconciliation post-discharge measure, as well as the removal of the Care of Older Adults pain assessment measure for 2027 star as well. There's also going to be the removal of the MTM comprehensive medication review for a while for star 27. There are probably another, I would say about 20 different kind of changes that are tweaks of given measures and other areas where CMS and STAR says they are planning or may do something, but there's not a lot of details. What I would suggest, if you are interested in additionally those areas, you can go to my April 8th blog at the blog tab of healthcarelabyrinth.com to hear more about those. So this sort of concludes the first third, or we may be running closer to a half, to be honest, regarding sort of the advance notice related to rates, as well as some star changes. And after the break, we'll come back and tackle the actual 2025 rule.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Thanks for listening to the podcast today. And we are now going to tackle the finalization of the 2025 Medicare Advantage and Part D rule. As I told you, these rules are sort of very important, and they are usually issued by CMS in a interim form every year, and then they are finalized several months later. And generally speaking, they're issued a little over a year before they go into effect. As I said, the 2025 rule was issued in late 23, It was finalized just recently, so it gives plans plenty of time to really move forward. There were a couple of key themes really in this 2025 Medicare Advantage and Part D final rule. First, there was a lot of anxiety on the part of CMS and advocates related to really poor plan oversight of marketing, as well as CMS oversight of marketing, and really the rise of what is known as third-party marketing organizations. So CMS in the last couple of years has spent a lot of time auditing plans related to their oversight of marketing. They have passed some other rules related to marketing, but this year they really were aiming to really curb what they see as major abuses by these third-party marketing organizations. Now, theoretically, these organizations do have arrangements with health plans, but it's very difficult for health plans to control them because they're acting on behalf of many different health plans, and really they're sort of entities unto themselves. So what did CMS propose for 2025 here? So CMS is really trying to take very reasonable steps to stop steerage of Medicare beneficiaries to plans that is based more on compensation and not the best interest of individuals. The way that many plans in third-party marketing organizations sort of got around the strict rules related to agent compensation was to come up with ways that the brokers or these third-party marketing organizations would receive volume-based bonuses to encourage enrollment in their plans over others. And so CMS was rightfully concerned about this. I said earlier that third-party marketing organizations were hard for plans to control. That is true. But also these volume bonuses were ways that they did work together to sort of subvert the intent of making sure that an agent is looking out for the best interest of individuals when they're enrolling. So what happens here is that CMS, in essence, has done a couple of different changes. Number one, volume-based bonuses to encourage enrollment in a plan are basically banned under the new rule. And CMS, in addition, redefines overall compensation for agents and brokers to be a fixed amount that agents and brokers can be compensated by MA plans. They originally proposed to have that fixed comp be slightly lower. In the final rule, they increased the overall fixed comp then that can occur. So in general, there will be some dollars going to the brokers and the third-party marketing organizations and others going to the agents. But this is a significant reform to really ban volume-based bonuses overall that weren't terribly regulated. So all compensation will really flow through this fixed amount that CMS is setting up in the rule. So I think it's a very good a reform by CMS. It also bars steerage language in broker entity contracts with agents. So that's an important point too. And the rule in this area also does not allow the sharing of personal data of people that the TPMOs sign up unless there's prior written consent. So that also protects the private information of people. Next, we're going to talk a little bit about behavioral health network changes. There has been a lot of concern on the part of CMS, advocates, and others that behavioral health networks within MA plans are not particularly strong. So CMS has added a behavioral network adequacy evaluation standard for a new facility specialty provider category called outpatient behavioral health. So this new standard will essentially enhance different kind of practitioners and facilities that have to be included within MA networks. It includes a number of specific providers, both for mental health and addiction services. And really, this is, I think, another strong move to encourage better network adequacy on the behavioral health and substance abuse and mental health sides. So I think I really applaud CMS for that change, much as I do the marketing change. So supplemental benefits is the next major category. Just as a quick backdrop, a lot of the growth in MA has been fueled by CMS's willingness to allow MA plans to add demonstrably to the benefits that are above and beyond what we think of as traditional fee-for-service benefits. And I won't go into too many details, but there's sort of three broad categories that these supplemental benefits fit into. And CMS is very concerned, and I would say it's fair, that the amount of money being spent on supplemental benefits is not what it really should be. Plans are making assumptions in bids about what the amount of per member per month costs will be for these various supplemental benefits, but it does not appear that the utilization is really that high. And so what CMS is trying to do here is say to plans, hey, listen, guys, you got to, if you're going to offer that benefit, you have to market and outreach to members, and you have to tell them that these benefits are available. And so this rule will require plans to engage in additional disclosure, and additional outreach related to supplemental benefits in a plan, including issuing a mid-year notice to members that informs them of the supplemental benefits in their plan that have not been used yet. So again, the aim is to increase the utilization of supplemental benefits here. If applicable, if MA plans have a given type of supplemental benefit that is restricted to chronically ill enrollees, there are some additional requirements. So number one, they must disclose during marketing that there are supplemental benefits only for certain chronically ill enrollees, and they do not apply to all enrollees in the plan. So that's an important reform. And as well, MA plans must prove to CMS that benefits to this chronically ill group and the supplemental benefits that are being offered must have a reasonable expectation of improving or maintaining health or overall function of the enrollees. So during that bid process, plans are going to have to prove that those types of supplemental benefits actually will make a difference in the health and well-being of people's lives. So again, I agree with these changes. I think it's up to MA plans to rise to the occasion here. And if they're worth their salt, they're going to help drive the uptake and the utilization of supplemental benefits in their plans. The next area that I'd like to talk about here is some additional changes on the utilization management front. So as we told you in 2024, the new prior authorization rule came in. I hate it, and I've said that in blogs and on podcasts. I think it's just a tragic rule, and it really takes a lot of what is good about managed care out of the picture. But there were a number of different utilization management changes beyond even just that prior auth rule that went into effect for 2024. There's one other major change in this 2025 rule. MA plans must ensure that their policies and procedures take into account health equity now. So again, a lot of focus on health equity, as I told you earlier, with the Health Equity Index in STAR coming in 2027. Big drive by the Biden administration. So plans have to make sure that health equity is part of the policies and procedures for utilization management at the health plan. In addition, at least one member of the committee that has been set up in an earlier rule must have expertise in health equity so that health equity is being considered. And MA plans must also conduct an annual health equity analysis of their prior authorization policies to make sure there is no discrimination from a health equity standpoint. So some important changes on related to health equity as well. Next, I'm going to turn a little bit to a difference between traditional fee-for-service related to outside appeal rights and what happens in MA plans. So currently, there are some outside appeal rights available, not only for denials, but also if a MA plan is going to stop furnishing certain inpatient hospital services. And basically, what a member has the right to do, whether they're in fee-for-service or in Medicare Advantage, is go to an outside reviewer to review on a fast-track basis whether the suspension of services in inpatient hospital is allowable or not. It's sort of a stopgap protection for individuals. So again, both MA plans and fee-for-service have that for inpatient hospital settings. However, there's a bit of a difference when it comes to facilities that are not technically inpatient facilities. In the fee-for-service world, members have the beneficiaries have the right to go to an outside reviewer when services are going to be terminated for skilled nursing facilities, outpatient rehab facilities, and home health services. There have been a number of complaints out there about MA plans sort of cutting off these services. So CMS is now saying that these independent review contractors will also hear appeals from members of MA plans related to the termination of services that they're notified about related to skilled nursing facility, outpatient rehab facilities, and home health services. So I believe on balance that that is a reasonable change. Again, I don't believe the prior authorization rule that essentially reins in prior authorizations for managed care plans makes a lot of sense, but I'm a little more sympathetic to outside reviews. I think they keep plans accountable to make sure they are using criteria that make sense when they're making decisions to terminate very important services. And so I think this is a reasonable standard to place for an MA member and make it similar to what happens in the fee-for-service world. Next, we're going to talk briefly about dual eligibles. And I believe that this is sort of a major area of change. There have been numerous dual eligible changes, dual eligible and special need plan changes that have been announced by CMS. Basically, the goal of CMS is to basically forge a very tight integration of the Medicare and Medicaid finances as well as treatment across these dual eligible populations and these dual eligible special needs plans that enroll these very chronically ill and SD, social determinant impacted individuals that qualify for both Medicare and Medicaid. And so some of those changes, again, drive the integration and drive greater integration and attempt to move away from just simply coordinating in a very loose fashion the two programs. And so some of these new changes go further down the road for 2025 in this area. So number one, there's a rule change to the special enrollment period for dual eligibles and low-income subsidy eligibles. Right now, it's a lot more liberal, and they're going to rein this in by allowing the current special enrollment period, the quarterly one, to only allow individuals to move monthly for enrollment in a standalone Part D plan, theoretically, to allow them to go back into the fee-for-service system. And they're creating a new special enrollment period to allow duals, though, to enroll in an integrated dual eligible special needs plan. So no longer on a quarterly basis will duals be allowed to change their SNP plan unless you're enrolling in an integrated dual eligible special needs plan, which is sort of the highest of the integrations DSNP types out there. And so I think actually that makes a great deal of sense. I believe that the special needs plans should have a very high level of integration, and they should be really held accountable, because we know that there's a disproportionate amount of medical costs that these dual populations utilize within both the Medicaid and the Medicare program. And I would note in the Medicaid program, their utilization is very high in both medical services as well as chronic long-term care. So again, this parallels some of the changes that are being done earlier. And again, it's meant to promote integration of Medicare and Medicaid. A few other changes that, again, try to limit more coordinated SNPs out there. There will be new limits will exist for enrollment in certain DSNPs to those individuals who are also enrolled in affiliated Medicaid managed care plans. So again, prioritizing enrollment in more integrated plans. Limits are placed on the number of DSNP benefit packages that an MA plan can have to sort of remove some of the confusion. The rule will also lower what are known as DSNP lookalikes, where benefits sort of look a lot like a DSNP, but you don't have to obey those very strict clinical rules in the DSNP. And so slowly but surely, they're going to eliminate the ability of plans to have these sort of shadow plans that look like DSNPs, but you do not have to meet all of the requirements and the investments clinically for those plans. And also, because of the rise of preferred provider organization, DSNPs, and some sort of, I would call, gimmicking, which essentially allows plans to transfer some cost sharing over to the Medicaid program, there is going to be limits on out-of-network cost sharing for certain DSNP PPOs to stop that cost shift as well. With that, what we're going to do now is we're going to take our second break before we conclude with some additional things related to the 2025 MA and Part D rule.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back to our podcast on a lot of policy changes going on for 2025 in the Medicare Advantage and Part D program. We ended before the break regarding dual eligible integration and some additional changes that are occurring, building on earlier changes that CMS has made. Next, we're going to talk a little bit about risk adjustment audit processes. So, as I alluded to earlier in the podcast, the master risk adjustment data validation rule is being challenged in court by a few plans really led by Humana. I happen to believe that CMS did not follow the Administrative Procedures Act And some of the things embedded in that risk adjustment data validation rule, including no fee-for-service adjuster in the formula, as well as retroactivity, is very concerning to me. And so Humana is challenging the RADV rule, and I believe there's a likelihood, in my view, that at least a part of that RADV rule will be struck down in court. Nonetheless, CMS is still trying to lay the foundation to implement risk adjustment data validation across all plans. I happen to believe we do need a risk adjustment data validation program to make sure that we have integrity in risk adjustment, because I do think there are some bad players. But I just happen to believe that CMS went a little too far in some of their policies in that rule. But the 2025 rule will build a bit on the RADV rule and basically limit what plans can do in that appeals process within a risk adjustment data validation audit. Plans would not, under this 2025 rule, be allowed to request both a medical record review determination appeal and a payment error calculation appeal at the same time. The overall RADV rule, again, is being challenged, and I think these sort of changes in the 2025 rule will probably roll up and be part of an overall challenge as well. I'm going to next talk about, close out here with a couple of things on the drug front, because I did say that this is the Medicare Advantage and the Part D rule. Generally speaking, Medicare Advantage is the medical side is sort of a bigger focus, but certainly there's a lot going on in the Part D world as well. We know that we have major changes from the Inflation Reduction Act occurring. I just recently wrote a blog, and I may do a bit of a podcast on all of the changes in the Part D program that are occurring that really save beneficiaries a great deal of money. And I sort of outlined them in a recent blog. You could go to the blog site and see that. That blog was actually posted on April 16th, I believe. So you could go read some of the Part D changes from the Inflation Reduction Act. In terms of Medicare drug price negotiations, we're right in the middle of those drug price negotiations right now. 10 drugs will essentially have prices set for 1/1/26. We are in the middle of that negotiation process between HHS and 10 drug makers right now. Overall, about 60 drugs under the current law would ultimately have prices negotiated or fixed by HHS. President Biden has proposed that there be 50 drugs subject negotiation per year over the next decade, which would mean 500 drugs would be negotiated. We don't believe that will pass in 24, but depending on what Congress looks like and who is president, there's the possibility that further changes to the Inflation Reduction Act's Medicare drug price negotiations could occur, and it could be expanded. And also there's a brand new rebate, inflation rebate, which basically says that annually drug makers cannot increase beyond a set inflation threshold. And if they do, they are required to give an additional rebate or face a penalty. And not only does Medicare share in savings related to that additional rebate, but beneficiaries who are getting their drugs will also see their cost sharing drop. So both of those are in the Inflation Reduction Act, along with some other Part D changes that I told you I just outlined in that April 16th blog. But I'd like to talk and close on two other changes on the drug side in the 2025 rule. Well, number one, MA plans will now have the ability to substitute biosimilars for brand biologics in a much greater way, much more flexible way. Right now, flexibility to make automatic formulary changes for these biosimilars versus the brand biologics is limited when a drug maker has gone to FDA to get an additional designation that is called an interchangeable biosimilar. And, theoretically, that is a protection for consumers to make sure that that biosimilar is truly interchangeable with the brand biologic. But the reality is, with biosimilars and generics in general, there is sort of the same efficacy between that brand drug or a brand biologic and a generic or a generic biosimilar. So, what CMS is saying is, because of the huge price tags associated with the brand biologics and the ability to bring down costs by having biosimilars at a much lower price, and if we could only get uptake and greater adoption to biosimilars, prices could come down even more. And so, in this case, what CMS is saying in that final rule is that whether you're an interchangeable biosimilar or one that is simply just a biosimilar in a given class, MA plans now do have a greater flexibility to make automatic formulary changes for those biosimilars, whether they're interchangeable or not. And so there will still be swifter ability to make changes related to the truly interchangeable ones. But I think this is a very important rule change by CMS to really promote the adoption of biosimilars out there. Much more needs to be done in the biosimilar world, including education of physicians about the efficacy of biosimilars, which should be as good as brand biologics, as well as stopping some brand drug makers from stopping the introduction of biosimilars, as well as putting some other gates in front of them with PBMs by offering rebates to keep the market share of the high-cost brand biologic out there. So I think a very, very good change by CMS in terms of biosimilar adoption and uptake. And the last area is related to the medication therapy management program. And so just a quick sort of understanding of what the MTM program is all about. So this is a program mandated in Part D that essentially tells plans for those individuals that have very major drug utilization that you need to fashion a therapy program. Some of the criteria used is the cost, the overall cost to that member for Part D drugs, the number of disease states that an individual has, and actually the number of drugs that a person is on. So within the parameters of what CMS sets out, plans are required to file their medication therapy management program criteria that cover those three areas. It's approved. And basically what plans have to do in this program is to conduct at least once annually a comprehensive medication review for these very high utilization drug users here. So one comprehensive medication review at least annually. And then for the other 3 quarters, generally speaking, the MTM program has to find other ways of intervening to promote good drug adherence, to promote drug safety, and other education on drug matters. And so this program has struggled over the years, frankly. Completion rates for comprehensive medication reviews has not been that great. And compliance in the program has not really been that great, and the outcomes have not been that great. But nonetheless, CMS is sticking with it, and they make some changes annually in the program. What the rule here would do is add as a list of disease states that have to be taken into consideration as the list of core chronic diseases. They are adding HIV and AIDS to that list. And they are requiring all 10 conditions to be in targeting criteria. So again, some modest, but I think important reforms to some of the criteria related to the medication therapy management program to get it a little more stable and more helpful in terms of outcomes. So with that, I hope you enjoyed sort of this technical deep dive into 2025 rates, some of the changes going on with the STAR program in 25 and 26 and beyond, and some of the major policy changes that are effective in 2025 for MA that really build on some other recommendations and policy changes that CMS has made before. And so with that, we'll conclude the podcast and we'll see you next time. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.